Cardiac arrhythmias. We are going to start the topic about arrhythmias. First, overview. In contrast to skeletal muscles, which contracts only when they receive a stimulus, but heart, they exhibit automaticity. And the depolarization is fastest in the SA node, that is the initiation state of the action potential, and it decreases through normal conduction pathway through the AV node. Now the classes are now see, dysfunction of the impulse generation or conduction of any number of sites in the heart will cause an abnormality in the cardiac rhythm. So these generate cardiac arrhythmias, abnormal rhythms. Class 1 is sodium channel blocker. Class 2 is beta adrenoceptor blockers. Class 3 is potassium channel blocker. Class 4 is calcium channel blocker and other antiarrhythmic drugs. Now introduction to arrhythmias and these classes, types of classes. Now atrial arrhythmias, atrial flutter and atrial fibrillation. Supraventricular tachycardias, AV nodal reentry, acute supraventricular tachycardia. Ventricular tachycardias, acute ventricular tachycardia, ventricular fibrillation. If the patient is having atrial flutter, we'll go for class 2, metoprolol, that is beta blocker. Atrial fibrillation, will first go to class 1, propafenone, then metoprolol, then amiodarone, then diltiazem, then anticoagulant therapy. Beta blockers are used in atrial fibrillation or flutter because they decrease the heart rate, promote conversion to sinus rhythm. Long-term oral anticoagulant therapy reduces the risk of stroke that is associated with atrial flutter or fibrillation. Atrial fibrillation is a common arrhythmia, involves multiple ectopic foci of atrial cells, creating a chaotic movement of impulses through the atria. The ventricular response may be rapid, 100 to 150 beats per minute, and irregular. Cardiac output is decreased and exercise intolerance is common. For supraventricular tachycardias, AV node reentry, will select metoprolol, then verapamil and digoxin because conduction is slowed through the AV node with metoprolol, verapamil and digoxin. For supraventricular tachycardias, we'll go for diltiazem and adenosine. For acute ventricular tachycardia, we'll go first for lidocaine, then amiodarone. And same for this, lidocaine, amiodarone, and then epinephrine. So these are the commonly used drug names which we opt for the conditions. Causes of arrhythmia are abnormal automaticity, abnormalities in the impulse conduction. SA node shows a faster rate of discharge than do the other pacemaker cells. Thus, it normally sets the pace of contraction for myocardium. If cardiac sites other than SA nodes show enhanced automaticity, they may generate competing stimuli and arrhythmias may arise. Most of the antiarrhythmic agent will suppress this automaticity by blocking either sodium or calcium channels to reduce the ratio of these ions to the potassium. Abnormalities in impulse conduction. Impulses from higher pacemaker centers are normally conducted down pathways that bifurcate to activate the entire ventricular surface. A phenomenon called re-entry can occur if a unidirectional block caused by myocardial injury or a prolonged refractory period results in an abnormal conduction pathway. Re-entry is the most common cause of arrhythmias and it can occur at any level of the cardiac conduction system. You see here, this is the normal. Nerve impulse arrives and goes to a ventricular wall. Unidirectional block. If there is a block, impulse is blocked in one direction. What will happen? Impulse travels in the retrograde direction and re-enters the conduction pathway. It re-enters here. So this is the re-entry and causing an extra or irregular beat. Now antiarrhythmic drugs. Antiarrhythmic drugs can modify impulse generation and conduction to prevent arrhythmias. This is the classification 1, ABC, 2, 3 and 4. Class 1 will act, 1A will act on phase 0, depolarization. In vascular, we have studied this. This was phase 0, 1, 2, 3 and this was 4. So here 1A will act. They will block sodium because sodium efflux was happening. These are all sodium channel blockers. They all will act here. Phase 0 depolarization in the ventricular muscle. Now 2 are the beta blockers that inhibit phase 4. So class 2 acts here. They are the beta blockers. And the class 3 will prolong the phase 3. So the 3 will act here, and these are potassium channel blockers. And class 4 will inhibit the action on SA and AV nodes.